welcome back to OMR series. Today we will be doing a structured discussion on oncology module, which is always a common task which people are worried about whether it is a long or a short case. So today I have Priya with me to be my examiner. Thank you, Priya, for joining. Yes. So to start with, just to remind all of you, your story might not have a happy beginning, but it doesn't mean that it is not going to end well. So just keep on focusing, revising, so that would help you to do better in the exams. Okay. So let's start off. This is the task which I have got. So we will start off with the task. Okay, Priya, I'm ready. Shall we start?
Yes.
Hello, I'm Sowmya, one of the exam candidates. I've gone through the scenario and I'm happy to start the discussion.
Yes. Hello, good evening. So after going through the scenario, what important information you want to know from her?
Okay, as a postmenopausal lady who is presenting with bleeding, of course, my history would be to understand the cause. So to start with, first, I would like to know the amount of the bleeding, what she has got, from when she has got, and as well, whether she had similar episodes after her menopausal time. And as well, I would want to know the alarming symptoms like bloating, whether loss of weight is there. As well, also, I would want to know any foul smelling discharge as well. And apart from this, I would want to know her about obstetric history, because if she's nulliparous, that's put her at a higher risk of having this endometrial cancer. And also, I would want to know the contraception use, what she has done during that time, if she has used the COCs as well. Coming to her menstrual history, I would want to know when did she attain the menarche and the menopause, and during the reproductive age group, whether she had intermenstrual and a postcoital bleeding. Of course, before postcoital bleeding, we need to know whether she is sexually active or not, and as well the smears, whatever she has got so far then. And as well, any HRT she has used after the menopause, and when did she attain the menopause. Apart from that, I would want to know her medical history, whether she has got any history of diabetes and hypertension, because those are the comorbidities which we need to be worried and they put at a higher risk of this. And apart from that, I would also want to know any allergies and support system, plus the medication use like tamoxifen, whether she has got, and anytime she has been diagnosed with endometrial hyperplasia and polycystic ovarian syndrome, because they are always put at a higher risk of having this. And also, if she has any medical problems, like whether she's on any anticoagulants, just to rule out, and also the parectal bleeding I need to be thinking, because she has come with the menopausal bleeding.
Very good. So what investigations would you like to send for her?
Definitely the bedside investigations, which I would want to do for her, would be a speculum examination first, to see if she has got any associated lesions which from the cervix itself. Apart from that, her general observations which we need to be doing. Apart from this, the blood test, like the full blood count, to rule out anemia and to see her general status, and LFTs and RFTs because of the age factor, and if I'm thinking of going for a surgical options as well, and also the transvaginal ultrasound to see her endometrial thickness. If it is more than 4 millimeter, I would definitely go for the gold standard hysteroscopic guided biopsy to see. If the endometrial cancer comes in, then I would be discussing with my consultant to go for MRI and the further test. Yes, there's one thing which I forgot to mention was the family history of endometrial cancers. If she mentions there, if at all, if it is there, then I need to think of Lynch syndrome, which mentions about talking about genetic counseling and genetic testing as well.
Okay. So she has undergone the hysteroscopy and biopsy, and it has come as stage 1B endometrioid carcinoma. So what would be your management for her?
Okay. So definitely this needs the patient to be called back for the OPD. So I understand probably MRI would also be done for her, because if it is, we are deciding the depth of myometrial invasion as well. So I would be involving multidisciplinary team, my consultant and the oncologist, and also the Macmillan nurse is the specialist nurse, to sit with her and to break the news for her. And the options available for her would be, definitely the best thing would be laparoscopic total hysterectomy. She could opt for abdominal also with bilateral salpingo-oophorectomy. However, this also needs her lymph node dissection, especially pelvic and para-aortic lymph nodes, because it is stage 1B, and it could be, it means deep myometrial invasion. And if at all, if it is a grade 3 tumor histopathologically and lymphovascular space invasion is there, I definitely would, we need to go ahead with lymph node dissection. Apart from this, there is a adjuvant radiotherapies which we need to be giving. The first thing is vaginal brachytherapy because of the stage itself, and external beam radiotherapy based on, because the myometrial invasion is more than 50%. That's why we need to be going ahead with this.
Okay. So what factors will influence the prognosis and the treatment response?
The first and foremost factor is the staging, cancer staging. So that is the first prognostic factor which we need to think of. Apart from that, the tumor grading. Grade 1 histopathologically is always well differentiated. Grade 3 is poorly differentiated. And myometrial invasion, once it is more than 50%, the chances of like spreading and the staging is more, as well as lymphovascular space invasion. And apart from all this, if she has the genetic thing like P53 mutations and the Lynch syndrome, obviously that can affect the prognosis as well.
Yeah, so we are done with questions, Dr. Sowmya, and you completed in almost 8 minutes. We still have.
Okay. Thank you so much. And like I forgot the family history, obviously,
Yeah,
about.
that was told at the end. Yes, so for the feedback, yes, very well then, Dr. Somya. So in history, you justified what all history you want to ask in her and why you want to ask, like in her contraception, especially if they are taking previous contraceptive pills, that may be because that is shown to decrease the risk of endometrial cancer, her obstetric history, because it is more common in nulliparous. So that all you were justifying. And the alarming complaints also that was asked. So that was very good patient safety point. Even the allergies were covered, and other medical comorbidities like the diabetes and hypertension, which can the cancer syndrome, which can increase the risk. Also, the history of PCOS was covered, so that was very good. And regarding our investigations, so that was that is bedside. So what you are going to do the per speculum, and then followed by the complete blood count and LFT, RFT for planning for surgery. So that was also very nicely told, and then followed by the detailed investigations, the MRI to know the myometrial involvement, and the stage 1B management was also told correctly, because it needs the lymph node dissection, because there is increased risk of pelvic and para-aortic lymph nodes involvement. So the mode of surgery was also told correct, that it can be a laparoscopic in these cases. And the prognosis, depending upon the P53, we know that is a poor prognostic indicator, and also the FIGO staging and the tumor grading. So that was all told correctly. Yes, family history though late, but it was covered. So well.
Yeah, one thing which I always, actually the bedside, I directly went to speculum. Ideally, I should have started with the BMI part. Obesity is something which I really thought late or very late. So I didn't actually mention about that. Fantastic. Thank you. Thank you, Priya. So let me brief you what it was. Thank you for your time. Yes, guys. Okay, so the history wise, obviously, I always remember going how you take the histories. But yes, probably I could have been a little more systematic about the medications. I remember the anticoagulation later on, which you could talk about. And yes, tamoxifen use, anticoagulation, and family history, as you know, I forgot, don't forget on that. And even though you don't remember BMI now, you can remember in the examination part. Of course, the examination, I think I mentioned all of this, but it could be a little more better, starting from bedside to lab and radiological. And investigations, once it comes, of course, first line management, MDT is very important. Always remember the patient you are talking to, MDT, breaking bad news, and how you're going to manage the treatments as well. And indications for the lymph node dissections, the more descriptive you are, it's always better. And endometrial cancers are easy when compared to the other cancers. And what factors? Yes, if at all, if you could mention about, and there could be additional questions of risk factors as well, so which I've added on. So unopposed estrogen exposure, like obesity, endometrial hyperplasia, PCOS, reproductive factors, nulliparous, early menarche, late menopause, medical conditions, Lynch, don't forget, medications, tamoxifen acid, and lifestyle factors. Lifestyle factors, they do say that protective for type 1, not for type 2. So you need not go into the details if you don't remember. Basically, staging of endometrial cancer is extremely important. If it is your long case, they're going to ask you the different stages of endometrial cancer. Because this we did like a short case, we just did one particular stage. It could be stage 2, it could be stage 1A, grade 1, which could make your life easier. So just remember the staging and staging wise treatment. Of course, I would tell you the competent and the non-competent candidate, history taking and the patient approach. See, if at all, if it is a patient, also you're supposed to be going about open-ended questions, because this could come as patient-simulated task also, right? Even if it's structured discussion, you have to show that you will do the breaking bad news things. And explanation of the condition in the management plan is very important. And what would you go about? Examination and investigations wherever. Have a structured and the logical approach. And you have to involve your consultant, the oncologist, multidisciplinary team is very important. And make sure you manage the time as well. Cancers, you need to know only 4: endometrial, ovarian, vulval, and which one I left, Priya? Endometrial, ovarian, vulval, cervical cancers. Yes. The most important thing which they always give is cervical cancer, young patient coming for nulliparous coming with earlier stages, right? So are probably BRCA coming for RRBSO. So just make sure that you know the pre-malignant and malignant conditions, because if it comes as a long case, then you have no escape. They would ask very, very deep. Okay. Thank you so much, guys. Hope that was helpful. If you haven't subscribed so far the channel, don't forget to subscribe. Okay. Thank you so much. Thank you, Priya, for being there. Thank you.
Thank you.